We are going to get started. This is the UCSF Osher Center for Integrative Health monthly research seminar. My name is Ariana Thompson-Lestat. I'm a research faculty member here. And today our seminar is going to be about a mind-body program integrated in shared medical visits for older adults with chronic pain in an underserved community clinic with Dr. Anna Maria Vranceanu. And Dr. Vranceanu is here. She's a clinical psychologist, the David T. Rovee and Joanne V. Rovee Professor of Psychology at Harvard Medical School, and the director of the Center for Health Outcomes and Interdisciplinary Research at Massachusetts General Hospital. Her research's program is focused on development, testing, and implementation of mind-body interventions in hospital and community settings with an emphasis on chronic pain, cognitive decline, interpersonal processes, and older adults. Dr. Vranceanu has been a PI on more than 30 research grants. She currently co-leads the Mass General Roybal Center for Behavioral Intervention, the Research and Education Core of the Resource Center for Minority Research there, and the Outreach and Engagement Core of the Mass General ADRC. She finds great joy in teaching and mentoring people on K Awards and in a T32 and R25 program. We're so glad she's here to speak to us. This is going to be a 1-hour session, wrapping up at the top of the hour. You are here already knowing how to use Zoom, but I'll just say about the Q&A that you can put Q&A in the chat, and we'll have the last 10 or 15 minutes be for questions. So that should be a good amount of time. And there's a little bit of blurb here at the bottom with a link to sign up for future research seminars. If you're not on the list already, we'll have another one coming up next month. And I think that's it. Go ahead. Oh, yes. Sorry. One more thing. This is our next research seminar, April 29th at 12. It's going to be on acupuncture research in military service members with Dr. Abanez, who's in the UCSF School of Nursing.
Great. Thank you so much, Ariana, for the lovely introduction. And it's really great to be here with you all. I have some slides I'm going to try to share.
That's good.
Okay, great. So I'm really excited to talk to you about our project focused on tailoring a mind-body program for the unique needs of older adults in an underserved community clinic to be delivered as part of group visits or shared medical appointments in both English and Spanish. The project is funded by the Health Equity Heal Initiative, an NIA-NINDS collaboration. And I have the good fortune to co-lead this project with Dr. Christine Ritchie, who is a geriatrician and palliative care doctor who many of you probably know because she moved from UCSF to MGH in 2019. So I have no conflicts of interest, but I have been fortunate to receive funding from many organizations, some of which are listed on this slide. So in our time together, I'm going to talk a little bit about my journey into integrative health and mind-body medicine. I'm going to talk about the need for mind-body interventions for older adults in underserved community clinics. And then I want to talk about this R61, R33 project that allowed us to tailor a mind-body intervention for underserved older adults with chronic pain. So the R61 phase entailed the cultural tailoring and an open pilot with exit interviews. And then the R33 was a type 1 effectiveness implementation trial. And then I want to end with some lessons learned and hopefully be able to pick your brain about some of the challenges we've encountered and some of the challenges we're still encountering. So maybe you have some answers and solutions. So I was asked to talk a little bit about my journey into mind-body interventions and integrative health. I really love that. I've never been asked to talk about this before. So I grew up in Romania during communism, and spirituality and religion were forbidden during the communist regime. I was a voracious reader as a kid, and during adolescence, I discovered the work of Mircea Eliade, who was a Romanian historian of religion, a philosopher, a writer who lived in exile. And he studies how people across cultures and times found meaning in life through religion, spirituality, myth, rituals, and symbols. And although he never used the term mindfulness, he wrote extensively about practices that help people become aware of themselves and the world, including the sacred versus profane, rituals, repetitions, as well as yoga. And so I started practicing yoga and using some of the exercises that he wrote about in his book. And once I was able, I left Romania, came to the US to study psychology and mind-body practices. And over time, I have become very interested in using the mind-body connection in the context of illness, with a specific focus on pain and more recently aging. And I developed several mind-body interventions, and I want to talk about two of them today. So why do we need to develop mind-body interventions for older adults in underserved community clinics? Well, about 60 to 70% of older adults in these clinics report some type of persistent pain, with many having pain in multiple sites, as well as additional comorbidities. We also know that chronic pain is associated with substantial emotional and social burden, as well as sedentarism and decreased in physical function. Chronic pain is complex in this population, also because of factors like discrimination, systemic racism, stigma, lower education, lower health literacy, as well as Medicaid insurance, all of which are associated with higher reports of pain, higher distress and disability, higher healthcare use, and lower quality of life. And we know that non-pharmacological treatments for chronic pain have the highest efficacy, the biggest efficacy. However, they are not available in underserved community clinics, and they're also not tailored for the unique needs of these older adults. So our solution was to take a mind-body intervention we developed to address chronic pain in primarily white adults in a major Boston hospital, culturally tailor it for the unique needs of this population, and then implement it in routine care. And we were focused on implementation from the beginning. And so we wanted the intervention to be delivered by providers who are already available in the clinic, and also be incorporated into billable group visits or shared medical visits, which already exist in these clinics, typically for the management of diabetes or lifestyle factors. So I'm going to tell you a little bit about these shared medical visits or group visits. So these are healthcare appointments where a group of patients with similar health conditions meet with one or more providers. And then they combine a medical evaluation that's usually done at the beginning with education, peer support, and counseling. And these interventions are becoming very popular because they are efficient and providers are able to see multiple patients at once. And so there is improved flow as well as reduction in wait times. There's benefit from education and peer support, so patients learn from each other and support each other. And these interventions are also cost effective because they have a medical provider either delivering the entire program or part of it. And so they're able to use these billing codes that are much more cost effective than the typical behavioral health codes. However, typical shared medical visits are purely educational, which really limits their potential efficacy. And so what we wanted to do here was we wanted to use the shared medical visit model and take an evidence-based program, an evidence-based skills program, and incorporate it in this shared medical visit to allow for a sustainability plan so that the practice could actually, sustain this intervention and get some revenue down the line. So this is our methodology. So we use the NIH stage model of behavioral interventions. This is very similar to the NCCH stage model that most of you are familiar with. And it has stages with activities that are included in each stage, and really takes an intervention from an idea to implementation. So we started with a mind-body intervention that we developed called Get Active. And this intervention has efficacy. And then we went back to a stage 1 where we conducted a cultural adaptation and developed this intervention that's tailored for these older adults, which we call Get Active Plus. and also conducted an open pilot to test the feasibility of this intervention. And this was part of the R61. And then we are now in stage 4-5, which is our effectiveness implementation testing through the R33. And then down the line, we're hoping to submit and conduct an implementation dissemination trial. So I wanted to briefly talk about that Get Active program that we developed and tested with funding from NCCIH, actually. So the program is based on the fear avoidance model, which predicates that people who catastrophize their pain or experience pain anxiety are going to avoid activities that are painful, even though those activities are safe, and they're going to develop and maintain chronic pain, while those who are able to engage in activities of daily living in spite of pain are eventually going to recover or have better outcomes. So using this framework, we grounded the rationale of the Get Active program as helping people move from a downward spiral to an upward spiral. So in the downward spiral, the pain triggers a pain alarm that initiates non-adaptive thoughts, unpleasant emotions, as well as a lot of avoidance, which leads to deconditioning, more depression and anxiety, and more pain and decreased physical function down the line. So the skills of the programs, which are deep breathing, mindfulness, cognitive restructuring, self-compassion, quota-based pacing, and enlisting support, are helping patients transition from this chronic pain downward spiral toward more of an upward spiral where they're able to regulate their pain alarm and eventually experience less pain and be able to engage in more activities of daily living. So this is our project overview. We call our study I HOPE, which stands for Improving Health of Older Adults with Pain Through Engagement. And as I mentioned, we have 2 phases. So our phase 1, R61, is completed. So in the first AIM, we conducted qualitative interviews and focus groups with providers and staff, as well as English and Spanish patients, Spanish-speaking patients. We used this information to develop the Get Active class tailored intervention. Next, we conducted an open pilot with exit interviews in English and Spanish. We established the feasibility, satisfaction, and acceptability of Get Active class, as well as its preliminary effect. And then we used the exit interviews from the open pilot to further optimize the intervention. And now we are conducting our phase 2, R33. So we're just starting this right now, which is aimed at establishing effectiveness of Get Active Plus versus treatment as usual in about 200 older adults. The program is delivered in English and Spanish. And then with patient feedback and provider feedback, we are also hoping to develop strategies to implement the intervention in routine care. So definitely by the end of the study, we will implement this intervention if we find effectiveness in routine care at this community health center. And then our next step is to get more funding to be able to do a national implementation, which is exciting. So very briefly, this is our conceptual model for the adaptation. So we followed the first 3 steps of Aaron's implementation model for adapting evidence-based interventions for use in community settings, supplemented by the socioecological model. So as I mentioned, in the AIM 1 of the R61, we conducted a lot of qualitative work. We did rapid data analysis to establish theme saturation really quickly, but then we actually did formal coding, formal data analysis using a hybrid deductive inductive approach where the levels of the socioecological models were deductive. And we use Gale's framework methods for actual analysis and data interpretation. And I should say we combine the provider and the patient data in our main paper, and then we also looked separately at patients and providers. So here are the demographics for patients. We had 34 patients, English speaking and Spanish speaking, as well as providers. We had 25 providers and staff. So you can see we had racial and ethnic diversity. Majority of participants were women. Income was quite low, as expected. In terms of employment, the majority were part-time employed. Majority were English and Spanish speaking. And when you see the provider type, we had a lot of various providers, primary care doctors, medical interpreters, nurse practitioners, but we also talked to administrative assistants as well as program managers to really get the perceptions of all folks who work in this clinic. So I'm going to present the results of the qualitative work based on each level of the socioecological model. So at the individual level, we learned that these are complex patients with stressors and medical and mental health comorbidities. And some of the information on the slide has been found in other studies. But what was really unique for this population was just as the high level of stress that both providers and patients talked about, as well as the high levels of trauma. And providers also talked about challenges that patients experience with following directions and medical recommendations, which really speaks of the low health literacy as well. Patients talked about pain shaping their sense of identity. They talked about going from someone who was independent, and that was really important for them, to someone needing to ask for help, which was really hard for them. They talked about pain affecting physical functioning, and that was a problem because their identity is also that of a caregiver. So these older adults were responsible for caring for grandkids in majority. Pain impacted social functioning. Patients talked a lot about isolation, but also shame of having this condition. Pain impacted emotional functioning, and in addition to depression, anxiety, and anger, they also talked about grief. So really grieving who they were, who they used to be. And they really struggled coping with pain. There was a focus on a cure. Everyone wanted the pain to go away. And they talked a lot about this sort of idea of having a fighting spirit, which backfires. So they consider themselves as being fighters, fighting the pain. But then when the pain would be too intense and then they would have to rest, then their identity would become one of a quitter. So these were really, really important things for us to consider as we develop the intervention. In terms of the interpersonal factors, there are complex relationships with social support and responsibility. So again, these older adults were cared themselves by other people, but then also they were caregivers themselves. There were also complex relationships with healthcare providers. So patients talked about physical therapists as pushing them too hard and not really understanding them. They were afraid to openly talk with their primary care doctors, particularly those who were taking opioids. They were afraid that if they were to participate in a program like this, that their primary care doctors would take their opioids away. And then for the Spanish-speaking patients, the medical interpreters were really their social workers. Like they would just call them out of the blue if they needed something, then they were so dependent on them. And patients also talked about pain being isolating, that no one really can see your pain, which was very distressing. At the community factors, the community level, there was a need for community resources. So our mind-body activity program encourages people to walk, but there were really challenges finding places to walk in the neighborhoods that these older adults live. And then there was also a need for culturally informed intervention. So there's sort of this need of respect for seniors, particularly, this older adults who are primarily immigrants or Spanish speaking. Within the culture, there's a lot of respect for seniors. And so that was really, really important for these older adults to let us know. And there was also a need for them to appear strong, in their interactions with primary care doctors and in their interactions with the people that care for them, as well as the people they cared for, which was really, really important to, for us to keep in mind. And then at the societal factors, there was a lot of talk about how the socioeconomic status as well as immigration status impacts availability of resources for managing pain. Immigration status is huge right now as we all are, sort of, in the middle of, many challenges. And so this is definitely impacting the work that we're doing right now. And then very interestingly, providers talked about generational differences in pain and pain care. So they talked about this idea of patients being set in their ways, which was really interesting to hear because that was not something that we experienced when we actually worked with these older adults. So it really speaks to some disconnect between the providers and the patients. These are some of the papers we published. So the one on top is summarizes the findings that I just described, but then we published a few other papers. We had a lot of really interesting information from the medical interpreters, for example. So just have them on this slide in case anyone is interested. So we took this information, this qualitative information, and then we tried to make changes to our Get Active program at all levels of the socioecological model. So at the individual level, we made the manual at third grade reading level to try to reach as many of these older adults. We talked about the interplay between stress and pain as it comes to activating the pain alarm, and worked with our participants to apply the skills that we're teaching them not only to manage pain, but also to manage general stress. We use a lot of pictures and a lot of graphics to just help these older adults understand the skills. We increased experiential learning and repetition. So rather than assigning a lot of home practice, we actually did a lot of exercises in sessions. And then we also introduced games. Participants really loved this Jeopardy game that we introduced again as a way to engage participants. At the interpersonal level, we focused on fostering a sense of community. We used a buddy system for skill practice. We worked to engage the larger family in activities. And then we really tried to foster relationships with primary care doctors as well as other providers and staff. At the community level, we offered the groups in English and Spanish. Initially, we wanted to offer them only in English, and we actually had funding to do this just in English. But then when we actually started doing the work, we realized we absolutely have to do it in Spanish, and we got approval from NIA and NINDS to do this. It was also important to understand and tailor content to culture within specific groups. So this community health center has about 50% immigrants. And so there's a lot of people from Eastern Europe, for example, who are very different than people who are maybe Spanish speaking. And so it was really, really important to educate ourselves on this and just really try to address culture within, for every individual. And we actually developed this case conceptualization forms that our clinicians complete so that we really have an understanding of where each person is coming from and how we might be able to further tailor the skills to each participant within the group. And then at the societal level, we had flexibility with scheduling groups. We worked on fostering new ways of thinking. And, obviously we're not able to, change, sort of immigration status or all these socioeconomic barriers that these older adults faced. But we worked with them to try to problem solve, as well as use mindfulness skills to cope with these challenges. Great. So this is the Get Active Plus intervention. So you can see it looks very similar. The framework looks very similar to Get Active. So it was really, really important for us to not change the mechanisms since we had efficacy as we moved into effectiveness, but do primarily tailoring. So one of the things that we did as a way to normalize pain and reduce stigma was to really talk about the pain alarm being triggered by stress, finances, responsibilities, grief, traumas, all these things that these older adults told us that they're experiencing. And then we further simplified the skills that we were teaching as a way to help these older adults understand the skills and then transition from this downward spiral to the upward spiral. And I'll talk in a minute about some of the changes that we made. This is our conceptual model. So we have our Get Active Plus components that are impacting theory-driven intervention targets. There's lots of them. And then in terms of the effectiveness outcomes, our primary outcome is self-reported physical function, but we're also looking at objectively measured physical function, so step count, as well as performance-based physical function measured with a 6-minute walk test. We're looking at pain intensity and interference, as well as depression and anxiety. And these were outcomes that were important to the patients as well as the primary care doctors. So within our open pilot with exit reviews, so our second aim of the R61, our primary outcomes were feasibility, acceptability, and fidelity. So you could see here, and this is across the English and Spanish, and then sort of separately for the English speaking and Spanish speaking. You can see that we did pretty well. We exceeded our benchmarks for all feasibility outcomes, which was really encouraging. And even though obviously we were not powered, for efficacy, and these results are very preliminary, I thought I'd shared some of the improvements in the quantitative outcomes. And you could see on the graphs, in orange, we have our Spanish groups, in blue, we have our English groups, and then in gray, we have everyone together. So you could see that there was, significant improvement in physical function, which was great. People also improved in the 6-minute walk test, a little bit less the Spanish groups, but definitely promising. We did not find improvement in step count, so the improvement was pretty small. So we're really working on that as part of the R33, and we made some changes. We found improvement in pain, improvement in depression, which was great. And then when we looked at mechanisms, again, this is preliminary, but it was really, really interesting to see that it seems like most of the changes it seems like there are some difference between the English and the Spanish groups, such that in the English group, we found improvement in pain catastrophizing, as well as mindfulness, actually use of mindfulness skills. Whereas in the Spanish group, we found primarily improvement in fear avoidance. And, I don't know what these findings are about, and we'll definitely see a little bit more when we have the fully powered trial. But I am wondering about, some of the words on the scales, and how this might have contributed to the difference in findings primarily for mindfulness. And then I thought I'd share some of the quotes from participants. I won't read them all, but I should say that this study has been really close to my heart. It's been, such a feel-good project to really be able to go in the clinic and see so much gratitude from the participants. We had, so the program has about 10 weeks, and most participants came to every single session. They wanted to have parties at the end, and they brought in food. Even though we wanted to bring food, they said, no, we need to show you the food from our country, and we really need to share this as a community, which was really exciting. And they also asked for copies of the manual so that they can share with their families, including mail them to, people from their country of origin, which again was really, really exciting and just meaning making for us. So some of the lessons learned from the R61 as we moved into the R33. So we learned that we needed to further simplify language. So particularly in the Spanish groups, some of the participants were even below the 3rd grade reading level, and some of them, even though the inclusion criteria was that they needed to read, some of them really, really struggled with this. And so we ended up further simplifying the language. we ended up doing more repetition to match the population learning style. And then we came up with this sort of buckets of skills that were color coded that you could see on the right-hand side. So we had activity, mindfulness, thoughts, and self-care. And we changed the mindfulness skills to be more sort of relaxation focused. And I know there's lots of sort of mindfulness scientists here who might not like what we did, but we ended up putting deep breathing in the mindfulness bucket, even though we know that's technically not mindfulness. Our participants really didn't like the exercises that were focused on, being mindful on your pain, for example. And you need a little bit more time and a little bit more practice to actually get to the point where these exercises are helpful. And so given the study population, we decided to focus more on deep breathing, mindful walking, mindful action, as well as progressive muscle relaxation rather than the body scan, which most participants didn't like. We did more in-session exercises. We changed the medical check-in a little bit. So each session starts with this medical check-in that's, kind of a check-in on people's health. We made it very specifically focused on pain and how the pain is impacting the activity. Particularly our Spanish-speaking patients, they loved to go into detail about all their health conditions, which really sometimes bled into the times for the skill practice. And we spent a lot of time training nurse practitioners and social workers to do this program, and we were really able to be successful and have a really, really good training manual developed, which has been really important as we moved into our effectiveness trial. So these are some of the sort of pictorials or skills that participants get in their manual. So as I mentioned, we didn't find much improvement in step count in the participants. And that was really important to the primary care doctors. It's really important to us. We know that the more you move, the less disability you have, the better your health. So we spent a lot of time talking to the patient in terms of how to improve this. So we landed on this sort of graphic that participants get in their manuals, and they wanted to do it paper and pencil rather than text or anything electronic. So where they really work on identifying planned activities, and then they say specifically how much time they engaged in each, and then they try to very gradually, there's a tendency to want to do too much too soon, but we're trying to encourage them very gradually to increase their activity. And then this activity tracker is reviewed as part of the medical check-in. And so this has been working really well in the R33. This is a quiz that's an example of a quiz that participants complete, again, just as a way to get participants to really master the program a little bit more. And then this is an example of a simplified visual of that sort of downward spiraled and upward spiral. And last one, this is the sort of, cognitive restructuring made very simple into catch, check, change. And I should mention, we also made flashcards for participants with all the skills, and they use these flashcards during each session, and the clinician is pointing to the flashcard, doing the experiential exercises, or where, they're processing, engagement in activities, or, meeting goals versus not meeting goals with participants. And those have been really, really helpful. So, as I mentioned earlier, we are really, really focused on implementation. One of the things that we've learned from both patients and providers during our early focus groups was that they didn't want another study to just come in, do the work, and then go away. They really wanted, us to make a commitment that we are going to, leave the program in this clinic. So even though, as part of our R61, we were not, focused on implementation, or we were a little bit focused on implementation, but we weren't, we didn't commit to collect data on insurance or think a little bit about the practicality of what we were doing. We actually ended up doing this. So we collected data on insurance and reimbursement rates to determine program revenue for the practice after covering for clinicians and supplies. And so our older adults were primarily Medicaid and dually eligible. And we were able to demonstrate for the R61 that if we were to bill, there'd be about a 20% revenue to the practice after billing if we use this sort of hospital-based model where we wouldn't have to pay for space or admin support. We're still in the process to determine the best billing codes for more revenue. I think there's an art here, and we're really trying to learn this. And we are also trying to think through how might we deliver group visits with a non-medical provider. So just a social worker or a psychologist for clinics who have them, and where nurse practitioners or primary care doctors may not have the bandwidth or interest to deliver this. So we're really interested to identify what might be the revenue difference depending on the provider. Our primary care doctors really wanted us in the R33 to look at what happens with opioids over the course of participation. Do patients start getting less opioids or ask for less opioids? And so we added this healthcare utilization markers to the R33, where we are now exploring deprescribing. This is our timeline for the R33. So again, we're really excited. We're at 65 participants enrolled, which is ahead of the timeline. We're again really excited that generally recruitment is going really well. Whoops. And I want to end with some lessons learned and some challenges. Initially, we experienced some challenges engaging primary care doctors in referring to the study, primarily because of the high burnout and turnover at this underserved clinic. We persisted and had a lot of meetings with the medical directors as well as administrators. We identified primary care doctor champions, as well as one administrative lead who are paid on the study, and that has been really, really helpful. I feel like the more patients went through the study and then they went back to their primary care doctors saying positive things about us, I feel like that sort of studied a positive snowball effect that led to more referrals. It was important for us to understand the politics of the clinic. When a clinic is under a lot of stress, there are interpersonal dynamics that are really, really important to be aware of as we're doing this work. It was important to culturally match the research team. So we have Spanish-speaking clinical research coordinators, Spanish-speaking social workers, Spanish-speaking nurse practitioners. Speaking with an accent was really great as I was talking to patients and providers as well, because 50% of providers and 50% of patients are immigrants themselves. The little things like food, payment for transportation and assessments, listening, really patience with those with health literacy were really important. We were open to let the qualitative data lead, but we really wanted to make sure that, the mechanisms of our interventions remain unchanged as we moved through the NIH stage model. Study swag helped. We had wool socks and wool hats and wool gloves for our participants so that they can be active during the winter. And then for those during the summer, we have baseball caps and water bottles. And we had some initial challenges training the nurse practitioners, but we were really excited that we were able to persist, and our nurse practitioners are very much buying in, which will be really helpful for sustainability. And then some of the challenges that we're still having that, I'm wondering if some of you might have some advice. Needing Social Security to receive payment is a huge barrier. I think it's much more of a barrier right now, where a lot of people are scared. There are many other languages spoken in the clinic, and we explored having the medical interpreters be trained to deliver the program. They have amazing relationships with the patients, but unfortunately, We got pushback from the larger administration just because the medical interpreters are in such demand that they didn't feel that they would be able to add this to their plate, even though we would be obviously compensating them. Systemic barriers remain. People have multiple jobs, high stress, trauma, low SES. And we are a little bit worried about billing and any copays that might be barriers to implementation. And I want to end by thanking the MGH team. It's a really, really amazing team, very dedicated to this work, as well as the Rovee Health Center team, who has been instrumental in allowing us to do this work. And thank you so much. And I'm going to stop sharing screen and see if there are questions. And it sounds like there are some in the chat. So I'm going to open and see. Okay, moved to Chicago slides. Okay, slides. I'm assuming that you'll be able to make the slides available. I'm happy to share. Have you considered live or online Qigong movement for pain? I teach pain management. Yes, yes. I think that sounds awesome. I don't have the expertise, in that, but I know that there is quite a bit of evidence. I should say that for our intervention, primary care doctors told us from the beginning that we should do this virtually. They didn't believe that the patients are going to come in for 10 sessions in person. Patients told us that they want to come in. So we said, let's just go with coming in. And it worked. They definitely want to come in. They want the community. They want to be in person, which is, it's very interesting because in this world where we're moving more toward, toward live video, these older adults really wanted to come in person. If you train nurses and doctors, they will recommend your program for seniors. Exactly. Absolutely. Yes. So I would say that in this clinic, the nurses, the leaders, and the primary care doctors are completely sold. I still think we have some challenges with, perhaps a biomedical model. And we are actually considering doing sort of a brief provider intervention around how to discuss psychosocial factors with their patients. That's, something that we're interested in doing down the line, but you're completely right, that, really getting that buy-in is helpful. I know that Natalia moved to Chicago. Thank you, Wolf. So I think that those were all the questions that I have here, but I don't know, since it's a small group, I'm also happy if people want to unmute.
You mind going back to the challenges slide?
Yes. Let me share again. Okay, I'm gonna use this. Okay.
Well, I can talk to you for a moment. This is Claire, the Qigong instructor. Fantastic research. I thought this was something that should have been done at Kaiser, when I was working there 20 years ago. So hats off to you for all this data that you've collected. I think it has a potential to be extremely helpful to hospitals and medical centers and clinics, in many places.
Thank you. Thank you so much.
I mean, it's the medical model for installing more of what you're suggesting, not just for pain, but for healthy aging.
100%. I couldn't agree more. Yes. Thank you so much for that comment.
Thank you for your work.
Okay, so I have the challenges here. I mean, I think these are challenges that probably most folks who do health equity or community work are facing.
When it comes to supporting the payment for these programs, one of the things that I've learned over 12 years of teaching, that you have to go where the people are economically. So if they have to pay something, they feel like they're invested. Even if you give it away, it doesn't have as much, I don't know, as much credibility, I guess is what I'm saying. That if you, even if they donate, that's one of the ways I teach outdoors. Sometimes I just let people donate whatever they can afford, and then they show up and they do the work, and it's really helping them.
Yeah, that's such a great point. Yeah, about the sort of reinforcement that, you're sort of paying something and um, you're sort of making a commitment.
Exactly.
Yeah, I think a challenge is, when you're paying, these copays are so high now. They're, up to $40. And then when you add transportation to that, you end up, having to pay $60, which if you make like $20,000 a year or something, is just quite a bit. But I agree with you.
That's very true. I just had someone call me about my online Qigong class, and she told me she was on Social Security and she only got so much money a month. And could I teach the class for less? And I think one of the things that we have to realize is that in this economy, people on Medicaid and Medicare and all of that, they have to budget for all these self-care and coping skills that we're teaching, because it doesn't come through their regular doctor visits or their prescribed visits for various ailments. It's a sideline. And I think we haven't caught up with that cost yet. And the only way I've been able to work with it privately is to let people pay what they can afford.
Yeah, no, that's such a good suggestion. Thank you so much, Claire.
You're welcome. My pleasure.
Wanted to ask one question. You were talking a lot about the qualitative research that you've done already, and I'm curious if you all are collecting more qualitative data in the current stage.
Yeah, so our second aim of the R33 is, we're going to conduct more qualitative data from patients and providers around implementation in particular. Yes, yeah, so we'll have another option, another opportunity at the end of this program, since it is a little bit different, and yeah. Yeah, I'm wondering if anyone has any suggestions around, the other languages. We considered, this some kind of translation devices, but they're not HIPAA approved. There's sort of all these barriers that we're facing. So I don't know. I don't know if anyone has any suggestions of any, sort of translating software that we might be able to use down the line, or clinics could invest in if we're not able to do additional translations or adaptations. I know it's a hard question. Sorry.
I don't have to input on the other languages, but I did have another question that was bubbling up. First of all, thank you so much for presenting to us today. It's really, really exciting to hear about the overall trajectory of the work, and congratulations on successful transition to the R33 phase. The question that I've been thinking about is, I was thinking about how Jeff Geller refers to the group inclusion effect, and how it's much easier to measure individual level outcomes. But I'm wondering how you've approached looking at some of the social factors like social isolation, as well as group chi or group inclusion effects and some of the dynamics that are happening within groups.
Yeah, this is such a great question. And, we're, so I'm doing the supervision, for the groups, and every group is so different. And you do have to, like, sometimes people click and they're just, sort of helping each other. And then other times there are sort of a couple of people that might not fit in. And so with what we're doing is, we have this sort of adherence forms that the clinicians fill out, but then they have to complete a case conceptualization for every person. So we're really trying to understand, when there isn't group cohesion, how might we be able to facilitate that? What might be some things that are getting in the way to try to get the groups to gel? I also think that our statistician probably is going to, control for group effects, in the actual main analysis. Because this is, you're right, like it's the actual group and the people who happen to be in the group. I mean, that makes such a big difference. And of course, the skill of the clinician as well, but also the people who end up being in the group. And congratulations to both of you for your transition to the R33. It's really exciting for sure. Yeah. I'm curious if you've experienced sort of similar barriers or found solutions or different challenges.
I don't have an
Similar.
answer about the question about multiple languages, but it does seem like it's a common. I just did a national survey of safety net clinics about group visits, and there are some that offer groups in languages that aren't Spanish or English, but it seems like it's a really common challenge. So I would love to be part of a big conversation of group visit people having a conversation about it and what are creative strategies to make it work. It does sound like the clinic that you're at has a lot more medical interpreter services than many organizations do. So it seems like it would be a good place to try doing more multilingual groups if there were resources.
Yeah. I have so we have a clinical psychology internship at Mass General, and one of the interns coming in, is Arabic speaking, and so we are potentially thinking about we were going to do a diversity supplement for her. That's not possible to actually do the do the cultural tailoring, but we're going to try to see if we might be able to do something. It's not all languages, but at least it's something. Yeah. And I love your idea. I think it would be really great to get together folks who do this type of work within shared medical visits together to just kind of put our heads together and work through these challenges. I think that'd be great.
Yeah, thank you for the wonderful talk. I'm a pain psychologist here at UCSF and love the work that you're doing. And we have been trying to come up with ways to do this type of work here. And funding, especially ongoing funding, is the challenge. So I wonder, how can we stay in touch with you? I know one of your challenges on the slides was finding out how to bill successfully for this. How do we stay in touch with you if you figure this out?
Yeah.
Will you disseminate your billing magic so that we can make something like this happen elsewhere?
Absolutely. I'll put my email in the chat.
Okay.
And feel free to email me.
Yeah, I would love to be able to do this here, and just billing wise, we just have not been able to figure out how to make it happen.
Yeah, it's so interesting because, as a psychologist, I never thought that I'm going to learn about billing because, I used to look at this as like, this is so boring. Like, I just want to work with the science. And then you sort of get in there and you realize that like this stuff is so important, in order to actually like be able to take what you develop and give it to people, in a way that people are going to be able to access it. And so, it's, I think it's really important to kind of, learn that stuff. So I made a commitment to learn it. It doesn't come easy to me, but anything I learn, I'm, happy to